Good evening, and thank you for joining us. I am Ellis Dean, the Director of Digital Programming and Production at blackdoctor.org. Tonight, we have assembled a special panel of experts and advocates to talk about a subject that many healthcare professionals who treat Black men have to know and talk about: prostate cancer. Specifically, we're going to talk about its impact on Black men, screenings, treatments, and most importantly, what else can we be doing to close the gap in treatment outcomes? Are you ready? Let's take care of some housekeeping first. First, let us know where you're watching from by dropping it in the comments. Also, if you know someone who needs this information, share it on your social media or tag them, because we like to get this information out to as many people as possible. And finally, if you have any questions, please don't hesitate to place them in the comments, and we'll get to as many as we can if the time allows. Let's meet our guests. Our first panelist is Dr. Fenwa Millhouse. Dr. Millhouse is a fellowship-trained, board-certified urologist and pelvic floor reconstructive surgeon in Chicagoland. Originally born in Nigeria, her family immigrated to the U.S. when she was a young child. She grew up in Texas and ended up at the University of Texas at Houston for medical school. She trained at the University of Chicago for urology residency. She was recently appointed on the board of the Chicago Urological Society. She is a wife and mother of 3. She is passionate about introducing the public to the world of urology, mentoring underrepresented minorities, healthcare disparities in the Black community, and diversity and inclusivity in the workplace. She uses social media to destigmatize urologic conditions, demonstrate the importance of representation in urology, and discuss healthcare disparities. Next, we have Dr. Wood Langford. Dr. Langford is an Oakland and Walnut Creek-based urologist specializing in urologic oncology and penile aesthetics. He grew up in the Bay Area and attended the University of California, Berkeley, majoring in molecular and cellular biology. He earned his medical degree at Meharry Medical College in Nashville, Tennessee, with a dual master's degree in public health from the University of California, Berkeley. Dr. Langford has a special interest in optimizing men's health with a holistic view on health and wellness, patient satisfaction, exercise, and lifestyle changes, which may influence positive outcomes after surgical procedures. He has a practice focused on penile prosthetics after therapies for prostate cancer. Finally, we have Mr. Terrell Whitley. Terrell Whitley is a filmmaker, entrepreneur, and visionary media executive leader of Liquid Soul, founding the company in 2001. Recognized as a millennial and multicultural marketing expert, Terrell has become a trusted advisor for brands looking to find impactful ways to target consumers. Throughout his career, Terrell has had many accomplishments, including delivering results for over 35 #1 film box office hits campaigns, 7 Academy Award-winning campaigns, and more than 300 other film campaigns that have grossed over $3 billion at the box office. Other accolades include a 2019 NAACP Image Award, membership in the Motion Picture Academy of Arts, and recognition as Entrepreneur of the Year by the Atlanta Business League. Terrell is also a prostate cancer survivor and advocate. Good evening to you all, and thank you for joining us.
Thank you, Ellis.
First question, Dr. Millhouse, could you give us the statistics on prostate cancer in Black men?
Good evening. So prostate cancer is disproportionately affecting Black men as compared to all other race groups. Black men are almost 70% more likely to become diagnosed. Prostate cancer, it affects approximately 1 out of 4 Black men, whereas white men, it affects about 1 out of 8 or 1 out of 9. Black men are a little bit more than twice as likely to die from prostate cancer. And this includes an increased risk in prostate cancer death, even among what we call low risk prostate cancer. So when we talk about prostate cancer, we like to say risk, and low risk prostate cancer can be viewed as synonymous as like early stage prostate cancer. So typically the type of prostate cancer that you should not die from. And so Black men are still at higher risk of prostate cancer death, even in this low risk group. Black men tend to have lower rates of screening and have lower rates of definitive treatment for prostate cancer. And so these are the really important statistics that we should all know, particularly those of us in the healthcare industry that treat men in any capacity.
So, listening to those disturbing statistics, Dr. Langford, if Black men are more likely to be diagnosed with prostate cancer, what could healthcare providers do to ensure their patients' treatment is both culturally competent and inclusive?
Yeah, that's a hard question to answer. But I think one thing I wanted to, first of all, thank you for having me. Really happy to be here. I'm really happy to talk about prostate cancer. I'm happy that we're putting so much effort into prostate cancer and making, increasing the awareness because of Dr. Millhouse. She just quoted a lot of statistics that, the disproportionate effect of prostate cancer, both in death and in diagnosis among African-American men. This is important. So we have to sort of focus on these things so that we can increase the screening, increase the awareness. Now, what can we do to combat the disproportionate diagnosis, in terms of lower grade prostate cancers are associated with higher death rates among African-Americans, right? In this big SEER study. So what can we do to prevent these things, from affecting us disproportionately? And some of the things we can do is have culturally competent care, meaning that we are organizing our care when we see patients who have risk factors, and these risk factors put them at increased risk, right? For cancer, for disease, for death. We use culturally competent care. We culturally approach them, and we try to have empathy and try to relate to them in a culturally competent way. Now, when they talk about some of the other interventions, of course, or when they try to understand why these genetic or differences in cancer exist, we always talk about social, cultural issues, socioeconomic issues, okay, socio-political issues. So that's what the healthcare provider can do. We can target our care in an empathetic way that's socially aware of where that person is, and and also economically aware of what that person may need to get the care.
So, Dr. Millhouse, what are some of the biggest challenges in the patient-provider relationship when it comes to the treatment of prostate cancer in Black men?
So, first of all, we have to acknowledge just the overall mistrust in our community when it comes to healthcare institution. And I'll say this, being Black in America, there's a mistrust of like almost every institution in the United States. It's not just exclusive to healthcare, and it's deservingly, we could have a whole week-long thing about every institution and how we have been mistreated and exploited. But particularly in that, unfortunately, with healthcare, you wish and hope, well, healthcare is the, big, one institution where things are pure, but that is absolutely not the case. There's a long legacy of exploitation of Black bodies and mistreatment and atrocities relating to Black patients. Long history. There's plenty of books out there if you want to read about it. And so we know about this. I mean, Black people, we know this. We often cite Tuskegee. Tuskegee is one of thousands of examples. But Black people, we know this. So we're already entering into this context. And the other thing is that studies have shown that when it comes to communicating with Black patients, there is this inherent implicit bias that many healthcare providers bring. And implicit bias affects everything we do. It's not, just, again, in medicine, implicit bias, all of us have it. It's just this kind of subconscious thoughts or notions we have about people based on maybe where they're from, how they look, what other attributes. And it's shaped by our world, and our world is very anti-Black. And so we have providers that have a subconscious bias, And it steps into the clinic room. It steps into the, conversations we're having with our patients. Absolutely. What I'm perceiving my patient to be is going to affect my speech. It's going to affect how my demeanor. Black patients report feeling less respected by medical providers. It's been shown that Black patients are less informed by medical providers. So this is a huge barrier, this patient provider relationship. It's already coming in, with hesitation, and then it's being perpetuated by this lack of cultural competency, as my colleague Dr. Langford has mentioned, and this, not recognizing our own implicit bias.
So Dr. Langford, I know this is probably what you're referring to when we're talking about the cultural competence. So when we're talking to providers, that's something that they have to have in their head, right? They've got to know when a Black man is walking into my office, or a Black person is walking into my office, they're bringing that with them. They're bringing that shared history, that knowledge of, and we have to assume, we have to know it, but we have to work a little bit harder. Would you say that healthcare providers, non-Black healthcare providers, even Black healthcare providers, have to work a little bit harder to overcome that distrust that patients walk in the door with?
Yeah, these are some challenges that we've had for the time that we've been in this country, in terms of obtaining resources and getting care, despite challenges like anti-Blackness, systemic racism. But I think if we sort of take a step back, and we understand that we have a society and a situation here that produces certain outcomes for our people, for African American people, for people of color, I think that there's two different ways we have to look at it. We have to look at it from the provider themselves, a provider who aims to give the best possible care that he can give. He has to sort of understand these societal issues that may prevent somebody from getting the care that they need, right? But then also the person who comes into the clinic, the person who comes in to obtain what they need for their life to live, they need to have a set of agendas when they come in so that they can get the care that they need. Because sometimes you're not going to be able to have empathy from that person standing next to you. And, there's been a lot that's been said about, you got the nice doctor, you have the guy who's got the good bedside manner, but does he have empathy? Does he understand the social, the cultural, the political, the economic issues that may prevent us from obtaining this care, which we'll go into more detail later. So I think two different sides, the patient and the provider, have to have empathy, have to understand the barriers to treatment, and have to be focused on getting them.
That's a good point. So, and this can go to either one of you. So there's been some recent stories suggesting that prostate cancer in Black men has a different genetic profile. The mutations that Black men have are different. These studies also suggest it's a more aggressive cancer, and at diagnosis present with a higher stage of cancer. So Black men are having a more aggressive type of cancer and present with a higher stage. Do you agree with these studies? And if true, what can providers be doing to learn more or to help close these gaps?
So early on in the search for why are Black men getting more cancers than white men, there was a lot of research focus on genomics. Like there must be a gene answer. There must be something in the genes. And, honestly, there are problems that arise in this. What are the genetic differences with black and white? Really, when we come down to it, there's not. I mean, race is more of a construct than a genetic difference. And so, largely, we have come to understand in the medical community, the urology community, that it's not really genes. I mean, there certainly are cancer. There certainly are cancer genes, that will predispose you to more aggressive forms of prostate cancer that absolutely exist. Now, whether, the racial disproportionality of this is not necessarily clear, but what is clear and what we are moving research towards is the fact that really more than like race is a factor, racism is the risk factor. The environment, the total and global environment that Black patients walk into within our healthcare system as it relates to prostate cancer confers more of the risk, of the higher risk of death and of disease than anything.
Dr. Langford?
Yeah, Dr. Milhouse, hit it on the head. I think it's one of those situations where, everyone's getting COVID. We got some Black folks who are dying disproportionately. Perhaps there's some genetic factor that makes these people die faster, and there's always this pontification on some sort of mathematical answer to why these things occur, when the big elephant in the room is systemic racism, right? That's what we know. That's what we know. And there's a number of books that have been written in regards to this issue, where people will get different care. Now, I think that that's an important point to make. However, I do think there are genetics, associated. And when I ask for genetics, I don't ask if you're African American or if you're Asian American. I take race off of my notes. I've always taken race off my notes. My questions are more generally: does your father have prostate cancer? Does your uncles have prostate cancer? Does your grandfather have prostate cancer? And I ask everybody that. And then I use that as a genetic test in terms of, genetic risk factor, if you will. But we know we have tons of genetic tests and sample kits that you can do in the office to really look at someone's gene profile to see if they're at risk for prostate cancer. If anybody's listening out there, there's Ambry, AMBRY. They can ask for that, and you can get a swab of your mouth, and that can give you your genetic risk profile for a lot of cancers. And also specifically in prostate cancer, there are a number of point of care sort of genetic profiles that give us a risk stratification for their risk of having clinically significant prostate cancer. But I do think that a lot of these disparities in why we die early, why we have late diagnosis, have a lot to do with the system of healthcare and how we find people who need treatment, how we find people who need biopsies. What's the impediments to people obtaining these biopsies so that they say they have prostate cancer? What's their educational factor? How much do they understand of what their risk is?
So Terrell, let's talk to somebody that's actually gone through this process on the patient side. So Terrell, what was it like for you when you first got diagnosed? What was that process like for you?
Well, it actually goes back to my dad. So Dr. Langford, you're right. What I first encountered was my father, who was going through surgery for his prostate cancer. I wasn't aware that he had prostate cancer, and he called and said, "Hey man, I'm having surgery." And he kind of explained to me what was going on. I flew to Wisconsin, where I'm originally from, and my dad went through the Da Vinci prostatectomy. Did I say that right? Prostatectomy. Which is effectively the Da Vinci Code, the Da Vinci method, which uses robotic arms to go in and really kind of attack the prostate appropriately. And after he finished his surgery, when I flew back home, I decided to go in and have early detection. And it was recommended. My dad wanted me to do it, as well as a doctor. And once I went and I got my PSA numbers, they were a little high. And then it was recommended for me to have a biopsy. So I went through that process, and I was with my wife as we kind of journeyed through that. And I will say that after the biopsy, and when I sat down with the doctor, and my doctor is Dr. Patel in Gwinnett County, the one thing I could appreciate was his direct nature in answering my questions and really just giving me the information kind of straight on. And as soon as he walked in, he said, "Okay, so you have prostate cancer." and here's what it looks like. Let's talk through the numbers. Let me make sure you understand what this is exactly. And he drew pictures and kind of walked me through the process. But it was very direct on. He didn't really cut the corners, and gave me the information. Now, for me as the patient, I can honestly say in that moment, my mind went to spaghetti. It just, you don't know what to think. Your mind just, mortality comes into play. My children, my wife, do I have things in order? All of these things. And one of the things he said is, hey, based on where you are, my job in this is to tell you that you will not die. If you and I partner on this process and we stay in touch, and we communicate with each other. And so he gave me great hope into the fact that this is something that is common, but also that there are solutions to go against it. So that gave me some comfort, although I can honestly say my mind was still spaghetti.
Can I say something?
Sure.
In a perfect world, we'd have plenty of time to say, you have prostate cancer. Let me let you sit for a moment and just digest this.
Mm-hmm.
And then let me go into the nitty gritty. Oftentimes we just kind of have to kind of go into it and then start immediately talking about okay, this is what, the recommendations. I really appreciate how he worded that part about a partnership. And this is going to be a journey. We're going to do this together. That means I need you to buy into this as a patient. If you don't buy into this, then this is where treatment fails. And oftentimes I feel like that's what happens with particularly Black patients is they don't buy into it for numerous reasons. So I appreciate that. Thank you for sharing that.
Absolutely.
That was my next question. I was going to say, Terrell, it sounds like he treated you more as a partner and a person than a patient. And alliteration aside, that partnership and a person is probably the most important piece to get you to do that buy-in that Dr. Millhouse is referring to.
Yeah, I think and you're right. Listen, Dr. Patel is at this juncture a friend, and he did treat me as such. But I also think I was receptive, right?
Mhm.
And it was my wife and I, we were together, we were in partnership on this. And so I think he respected that and he leaned in because I also leaned in. Now, I think that my ability to lean in was also connected to my father and the fact that my father had just gone through, he was actually going through his journey. So after the doctor spoke to my wife and I clearly remember going to the car and I sat there in the parking lot for quite some time. And the first call that I made was to my father.
Mhm.
And, he and I spoke and I cried and kind of got a lot of it out of my system. But I think it speaks to community. And while I agree with the doctors and kind of, the patient doctor relationship, I'm also a big believer in our community's ability to have these conversations and not feel embarrassed, not feel shunned upon. And I think that the community of men specifically is a very difficult nut to crack. And then when you go a layer deep into Black men, oh, you done got into a mystic area at that juncture of trying to understand us. And so the blessing for me was that I had another Black man that I could turn to right away. It wasn't over time. I could ask some very pointed questions to him up front, being my dad. And I felt like even if he didn't have the answers, he would listen with a certain level of clear empathy, and say, "Hey, man, let's just continue walking through this." So I think that's tremendously helpful, which is what I do today. I realize that other Black men have questions that, quite frankly, I think day one, they kind of feel a certain way about talking to the doctor about it. And they want to find out, okay, who can I have this conversation with, and feel okay and feel comfortable, but also feel as though they're going to give me a qualified, at least it may not be a medical, but a qualified level response to say, hey, I hear you, I understand you. Here's some things to think about.
I just wanted to say one thing that really I think is important for your story, and it was really great story. I think that partnership again. I love that the doctor said, "Look, this is a partnership. You won't die." I do that a lot. I say, "Listen, this is not a disease that you're going to die from." But I think one of the things that we missed there was the fact that you were coming in to seek care, saying, "Hey, my father has prostate cancer. I am trying to early detect my prostate cancer." So when you come to a doctor with that mentality, it's a different reality going on. It's, oh, he's coming to prevent his disease. He's coming to partner with me. And I think that's what we need to tell other Black men, is that you need to be proactive. Now, a lot of times guys are intimidated. And I hear this a lot when they go in with other providers and they say, "Oh man, he acted like he didn't even want to talk to me. He just got me out of there." And that's when you have to go and pursue your best interests, and that's what's tough. But it's almost like if you're a salesman and you're like, and you got to tell them, "Hey, listen, I need to get my PSA screen. I need to make sure I don't have prostate cancer." "Well, you're fine." "Well, I don't think so. I need, you got to pursue your self-interest." And you pursued your self-interest, and I thought that was awesome.
Yeah, I know coming in, he talked to me. I was a Gleason 6. I think my volume was 3/12 based on the biopsies. Stage, I guess that was stage 1, kind of 1, 2. PSA was 3.3. Like I got all into these numbers, right? But trying to understand, okay, what am I dealing with? And the great thing was his ability to break it down, help me and my wife. But the reality is that for me, it goes beyond the numbers, and you start thinking about quality of life and how is this going to impact my relationship with my wife? How is this going to impact how I feel as a man? What happens, for as our relationship and our relations? And those are kind of the things that in that immediate moment, day one, you just trying to figure out how to process it. Like I said, your mind is going many, many different directions. But you're right. The partnership, I thought, and like I said, he is a friend. It's to the point, he gave me a cell number. He said, "Call me, text me." I realize every doctor can't do this. But he was very, his empathy was at such a high level. And I think, again, it was the approach that I took up front that really emphasized kind of how our relationship would grow.
And that's the key, right? Is understanding. And so when we're talking to the healthcare providers that could be watching this program, I want you to really listen to what Terrell is talking about, right? So he dove into the numbers. Yes, he had some extraneous people that could help him in terms of on this process. But when he goes into the doctor's office, he needs to have a partner there as well. So he had his partner in his wife. He had a partner in his father that he could talk to, both of them there supporting him. But he also needs a partner at the doctor's office because he's the one that's going to have to go through that. And he's going to be working through that with his doctor. And so healthcare providers understanding that partnership is an extension, and it's got to be clear and concise and respectful and trustworthy all the way through. Because if he goes to his wife and his father and he goes to the doctor and he's not getting that same partnership level treatment, there could be some breakdown in that process. And that's what we're really that's what this whole program is about, overcoming that breakdown. That could be a simple communication breakdown, a stylistic breakdown, whatever, but we're trying to repair that and build that bridge so we don't have so many breakdowns in partnerships where we have this really high level of Black men dying from prostate cancer, which is a very treatable, as we all know, a very treatable condition.
Yeah, can I say something real quick, Ellis?
Sure.
Yeah, I think one of the things, and I've heard this from other men that I've spoken to. Number one, some just don't want to know. Like I don't even want to know. Like I'm just, and here's the deal. I didn't have any really core symptoms. There wasn't anything that would have told me other than my PSA number that I was dealing with this. And I've heard men say, "Hey, I don't want to deal with this." Or the other part is, and my doctor told me this, is like sometimes men come and they find out, and specifically Black men are like, "Cool, I'm gonna eat better and go pray." And that's it. and I'm gonna go to church, and we gonna knock this cancer thing out. And they lose track. And I remember I did wait and watch. I had a wait and watch period, and during that period, I focused so hard on my health. I feel as though I got into really great shape, and my numbers actually got better. My PSA number dropped, and I remember my doctor saying to me, he said, "Terrell, I don't want you to have false hope, and I know that you're doing the right thing, but let's just continue to walk this down." And then during the next cycle, my numbers they drastically increased, and that's when he said, "Hey, now we have some decisions to make." But if I would have taken that premise of, hey, I got the number from a 3.3 down to a 2.6, I'm good, healthy, doctor, I'd have beat this with my herbs and working out, I'm not coming back, right? I think that would have greatly impacted my overall outcome and where I am today.
Dr. Langford, I saw you laughing. You've heard this. Sounds like you've heard that before.
Yeah, it reminded me of denial. A lot of times when you tell people that they have prostate cancer, there's a denial. And then also a lot of times, especially in the Bay Area, I used to practice up in New York, and it was a little different culturally, had to get something used to. The Bay Area, people do a lot of herbs. New York, sometimes it depends on the area that you are in New York, but in the Bay Area, in Oakland, people do herbs and people do a lot of holistic medicine, which is great. But sometimes, they're like, look, man, I can go and to a shaman and cure this thing. Or, I heard my friend who did that too, and I'm gonna do that. And it's like, you could, but I'm gonna tell you the statistics of who died. Let's go to the Memorial Sloan Kettering Norma Graham website and let's put in what your disease is and let's look at the survival. And I can guarantee you that there's going to be in the 90 percentile survival. Can you guarantee me when you take this holistic herb that you're going to have 95% survival? So those are the kind of things, we struggle with as a community, which is good because I think that holistic health is important. Optimizing your health. And there's a lot of data to a antioxidant rich diet from UCSF actually, which, prostate cancer preventative or things of that nature. And so I think that those are things important. And I always tell people to optimize their health, eat tons of antioxidants, go vegan if you can, plant-based whole foods diet. And that can be your holistic sort of medicine.
So, Dr. Milhouse, help us set the stage, because I know both of you are urologists, and so there's a process, right, before we get to diagnosis. So, help us set the stage of what that process is for a patient, and then Terrell did a good job of really talking about that mindset when you get to that end and you hear you've got prostate cancer, right, and this perfect spaghetti mind where everything's all over the place, but what is that process like? And really, where along the way do we feel like we're in that process? Are we losing Black men when they're stepping away and they're not coming back till it becomes almost too late when they're coming in their later stages?
So the process should begin with a conversation. Okay. We are no longer in this world of medicine where it's like, I'm the doctor, listen, you do as I say, I'm writing out the prescription, just do as I say. I'm not going to explain. So it begins with a conversation. Hey, you are of this age. You are a Black man. We should talk about potentially starting to screen you. These are the pros and cons. Okay. In medicine, there's almost always potential for cons. So, we're screening you and we treat you. And one of the cons is you get a side effect that decreases your quality of life. And, so we go through this conversation about screening. I have a conversation about screening before I start screening any man. And for Black men, that is probably going to be at a earlier age than non-Black men. The American Cancer Society recommends starting screening for Black men at 45. The American Urologic Association really wants this to be more individualized. They don't make a direct age for Black men, they do say this, that Black men should be considered in higher risk than average risk men. So therefore, screening at earlier age, it should be considered. And you know, most of that will probably fall sometime between age 40 and 50. I think I don't, you're hard pressed to find somebody to advocate for screening younger than age 40. Okay. So then we do this blood test. Now this blood test, blood test is called PSA, prostate specific antigen. It's a blood test, non-fasting. And this blood test is not perfect. You could have a PSA that is higher than the quote unquote normal, which the cutoff really is around 4. Some PSA labs will do a cutoff of 2.5 or 3, depending on your age, if you're like under the age of 50. But 4 is kind of like the general cutoff. But we know that PSAs above 4 doesn't automatically mean prostate cancer. And in few cases, PSA below 4, you can have prostate cancer, like our guest here, Terrell, whose PSA was actually below 4 at his diagnosis. Then nowadays, we used to be a nail to a hammer. So PSA 4.01, must have biopsy tomorrow, and we immediately biopsy the man, which is, not horrible. There's a lot of more horrible things we put patients through medicine, but it's not fun. A biopsy in the office through a rectal ultrasound. We are not like that, thankfully, anymore. We are much more strategic, we are more thoughtful, more individualized. So, there is oftentimes, probably nowadays, there may be there should be few steps before PSA to biopsy. For instance, repeating your PSA, or something that's become recognized as really should be a standard is a prostate MRI before a biopsy. The American Urologic Association has recommended an MRI before an initial biopsy in all men that can undergo an MRI. And we see now more and more insurance companies are approving this, this pre-biopsy MRI. So
why is that? I want to stress that. So why is that MRI now being recognized as something common practice? And why is it important for men to know that is part that could be potentially inserted between PSA and the biopsy?
So prostate MRI can be helpful to two things: can help stratify patients that have, an abnormal PSA or concern, but, maybe we want to know, do we really feel like we need to do a biopsy or not? Okay. So it can help kind of put patients into a group of, hey, I think we really should do a biopsy, and oh wait, this MRI looks pretty benign or not suspicious. Let's just follow your PSA more closely. So it can help avoid biopsies, just this blanket biopsy in everyone with a PSA above 4. The other thing is the prostate MRI has been used as a targeted way of doing a biopsy. So we get an MRI, and the MRI gives us a lot more detail, and then we can use that and fuse that with a biopsy that we do in the office. Traditional prostate biopsy is done with an ultrasound in the rectum. But if we use the results or the data or the of the MRI, it can help us to understand and target the area for biopsy, so we can potentially get a more reliable biopsy. So those are the two ways that MRI has changed the game and has become adopted as a standard of care prior to biopsy. Dr. Langford, jump in if I'm missing something here. But that's I get an MRI on virtually everybody before biopsy, unless they can't get an MRI for, they have metal in their body or something like that. So that is oftentimes the steps. So it's not this, patients should know if they have a PSA come in, abnormal PSA, that it really is maybe, months down the line before we even say we are ready we think you need a biopsy. And that's for their benefit. That's for their good, to really not be a hammer to a nail, to really we want to diagnose the prostate cancers that matter. And not avoid subjecting men to treatment and to interventions that when it doesn't matter. Other tests that might be used, there's a plethora of like blood tests that go beyond a PSA that that include other PSA forms or other proteins. There's something called 4K score, which is a blood test. I think there's another thing called PCA3. There are urine tests. Urine test kind of came about and they were kind of like, ooh, this is cool. You know, patient just urinates and we can look at DNA and try to risk stratify and see. And I feel like urine tests are kind of fallen by the wayside now with MRI, prostate MRI kind of moving in. But those are that is the gamut of things that might happen that get you. And then once you get to a point where, okay, prostate biopsy is probably recommended because of all this other evidence, then it's a biopsy and it's typically done in the office. Although it might be done in a surgery center or operating room, depending. And there are a couple different ways. Most commonly, it's done through the rectum, through a small ultrasound. This is where we might lose Black patients because Black men and their rectum are such a touchy subject. Very touchy. And so
yeah, don't touch it.
So, but yeah, so, you know, being able to talk to a patient about these concerns, you know, I understand this is going to feel weird and not, you know, natural potentially to you, but this is, and really calming them down. You know, I talk through the whole thing. You're going to feel my hands. It's going to be lots of pressure, you know, to kind of, you know, work through this. I understand that a man is thinking you're doing what to where,
Right.
you know, so that is a common place. I feel like Black men kind of delay and avoid.
Yeah. Dr. Langford, anything else? Any other screenings? Because we need to talk about treatments. I know we got about 18 minutes left, so I do want to talk about treatments and next steps. But any other screenings that you can think of? I think Dr. Milhouse did a pretty good explanation on.
Great, comprehensive.
So I want to stress to the men that could be watching this program about that MRI, which is why I stopped and had her really describe it, because that is a game changer for people that could be squeamish potentially about the biopsy situation. And so if you know that you have an elevated PSA, or even if it's not over 4, but you've had a jump from 1 year to the next, that's assuming you're getting annual screening. So I'm going to assume that you're doing what you're supposed to be doing. But if there's a jump from 1 year to the next, so like you came in, you were 0.7, and then the next year you had 2.3, that's a significant jump. Even though you're under 4, if over year to year you had that kind of jump, there could be something going on. You could get that MRI in between before you get the biopsy that could give them that picture, and then that could help give more information to your urologist. So
the only thing I would add is that sometimes the MRI psychologically prepares people. Mm-hmm. Sometimes if you just have a blood score and you're like, whoa, 4.0, and then you say, oh, you got an MRI, we see a lesion here, I want to biopsy this lesion, you know, it makes them more psychologically sort of settled to say, okay, I need to get this biopsy.
Gotcha. So what are some of the treatments? I know we've talked about, Terrell talked about his dad having surgery. Terrell, I'm assuming you had surgery.
I did. I had the same process as my dad, the robotic surgery.
Are there any other treatments options available? I've been hearing something about some medications that could be taken. Or what are the treatment options available for somebody that has prostate cancer?
I guess I'll tackle that. Dr. Milhouse, feel free to jump in. I'm not quite sure what you mean by the pills, but I think essentially when I have a conversation, let's say Dr. Milhouse kind of walked you through obtaining your biopsy. So let's say that the biopsy is come back and I'll have them in the consultation room and I'll have the pathology results from the biopsy and we'll discuss what the pathology results entail. Now, I always tell them, hey, your biopsy is either negative or positive. That's the first step. And so they're like, okay, if it's negative, we high five. I'll see you later. If it's positive, then we have to talk about, is it clinically significant or clinically insignificant? And so if it's clinically insignificant, then there are treatment options, right? And one of our treatment options is actually the lack of treatment, but I see it as a treatment option because I was really interested in active surveillance 10, 20 years ago when I was training. I thought it was such a beautiful way to treat people, was to watch and wait and selectively intervene. And that's exactly what active surveillance is. It's watching, it's seeing that you have prostate cancer. It's saying that the prostate cancer is not clinically significant enough to kill you or to cause you harm within the next, year to two. So we are going to watch this disease using the PSA and even using MRIs over 2 years or so and see if there's clinical progression of the cancer. So that's one of the treatment options is active surveillance. And let's say the prostate cancer is clinically significant. If the prostate cancer is clinically significant, meaning it can cause death to you or a problem to you, not necessarily death, but a problem to you within the next 2 years or so, then treatment is recommended. And so when we talk about treatment, the treatment options or treatment is, I just break it down: radiation, surgery, right?
Okay.
And usually radiation has a lot of different forms. There's some sexy forms, cyberknife, or, proton therapy. All of these are forms of radiation. And radiation is using isotopes. It's using radiation or, hazardous sort of, I don't know, I'm not a radiologist, but, it's using radiation to kill tissues. So killing the tissue is hopefully controlling the cancer, stopping it from spreading. Usually radiation is accompanied with hormone deprivation. Testosterone feeds prostate cancer. So I always talk to them about depriving your body of testosterone via a pill or a shot to stop the cancer from being fed so it doesn't grow and it doesn't spread as easily or as fast. So my treatment regimen or my treatment discussion is usually radiation therapy or surgery. Surgery is removal of the entire prostate and removal of pelvic lymph nodes. I usually do pelvic lymph node dissections. I mean, sometimes you don't have to in very low risk disease, but some would argue that maybe you should just be doing active surveillance in low risk disease. So I do pelvic lymph node dissections most of the time, unless there's some sort of contraindication, but removal of the entire prostate and removal of the seminal vesicles in every part of the prostate, and then putting back together the bladder and the urethra. And so that's the surgery. And then sometimes you may need radiation after surgery. I always talk about that as well, because sometimes people think that they may have gotten out of radiation by doing surgery, but sometimes the pathology after surgery is adverse and it tends to need more treatment with radiation.
I'd like to add, that was great. That's basically the dichotomy. And we're all of this is assuming the prostate cancer is still in the prostate. This looks very different if your prostate is outside of if your prostate cancer has spread to other parts of your body.
Right.
But there is, I want to just say it out there because patients may see this, hear this, want that. There is growing interest in focal therapy, meaning radiation and surgery. Both of those therapies, like, basically try to get to the whole prostate as a gland. Like there's prostate cancer in here, let's treat the whole prostate. Focal therapy tries to treat the prostate cancer in kind of in a way that says, oh, prostate cancer is just right here in this part of the prostate, but we're going to spare the rest of the prostate. And there's, like cryo where we can freeze the part. There's laser, focal therapy. There are other forms. And really, patients should note that, number one, the long-term cancer control effectiveness is not as good as more kind of whole gland therapy. Not to say that no one should ever get focal therapy, but there is that caveat. And so you should be, if you get focal therapy, followed even more closer. So your follow-up after focal therapy does not look like a follow-up after you had your whole prostate removed. The other thing is that a lot of these focal therapies are being done at academic or large institutions in the setting of clinical trials, as they should, because again, we're learning more about this. We're still learning. So that's the thing, because people always undoubtedly ask about some laser. Can I get the laser? People love the laser. So that's my only addition, but very good job, Dr. Langford.
No, definitely. Focal therapy is something I believe in it. I think it's still, just as you said, it's sort of it's being validated at the academic institutions right now. You can get it. UCSF is one of our local places that does it. Also at Stanford. I've done some myself in terms of viewed, and so I think it's a promising procedure that will be available to treat prostate cancer in the future, more readily available.
Yes, I agree, and I think for the right person. And again, the idea with the focal is let's treat the prostate cancer without throwing the whole kit and caboodle out, and then reducing side effects. That's the bottom line. Is like, let's have a treatment that has less side effects.
So are either of you familiar with ADT therapy?
Yes. Oh, yes. ADT.
Yeah. That's what I was explaining. The testosterone feeds the cancer. So ADT is androgen deprivation. It's stopping the testosterone from feeding the cancer. There is a newer, some people may be asking about the ADT pill. There is a Orgavox, I believe the name is. It's a newer androgen deprivation therapy that you can take as a pill. So it's different than getting a shot for androgen deprivation therapy. But I just feel like I should answer that because I did maybe make that more clear,
No, that's good. That's very good. So as we're getting
ADT
close,
is usually reserved for like advanced prostate cancer. Not somebody like Terrell that presented with his thing, because
as a primary treatment.
Yeah, exactly. Giving ADT then reduces your testosterone throughout your whole body, not just the part that goes to the prostate. So there's implications to that. So, but it is very effective in a lot of cases of advanced prostate cancer.
So I want to kind of move to with the time that we have left here into what's next. So Terrell, and you talked about becoming an advocate after your experience with prostate cancer. What's some of the advice that you give to men, not only about prostate, but about their overall health when you talk to them as they start their prostate cancer journey?
Sure. I think, well, number one, it took me a minute even after having surgery, and I had my prostate removed, and the side effects can be traumatic for some people. Specifically, if you have incontinence, that that can do something to you and make you feel a certain way. I was diagnosed at 40, so I was pretty early. I did wait and watch for 2 years, and then I had my surgery. And then, of course, men want an erection, and that's a big concern. So I usually start right at the top when I'm talking to other men. And the biggest thing is they want to ask questions, what's going to happen to my quality of life, and specifically my sex life? Am I going to have an erection? I've heard that this thing can eliminate that and things can happen. And some of it is very, very true, of course. And, for me, especially with the men that I talk to at a younger spectrum of age, I'm saying, listen, what my doctor said to me was like, you're in great health. You don't smoke. You're not overweight. You don't consume tremendous amounts of alcohol. This particular surgery and my method of going after it, I think, can be very successful, but it's not 100% guaranteed. And there's some things you're going to have to do afterwards to put yourself in a very high margin of success. And so what I try to do with the guys that I speak to is, number one, stay in front of your health screenings. Go get checked, ask about your PSA, ask about the process of what happens if it is elevated. I did have the biopsies. They are not fun. And I had to go through 2. That means 24 snips. It was rectal base. It was weird. It was not. And the first time was in a clinic. I was under. Second time, not so much. And so you're right. It puts a little hesitancy in your posture around, okay, I want to address this. For me, and what I tell other men is, what's your reason why? Like and for me, my reason was, my girls. Honestly, I had two beautiful girls, and I told my wife, I said, one of my greatest desires is to walk these girls down the aisle. And so I need to try to be here. And I ask other men, okay, what's your why? Why are you going to go through this? What makes this important? And hopefully it's beyond yourself. Selfishly, it needs to be around something, somebody's, something else. And for me, it was, of course, because the thought of mortality comes into play. And I think that part is something that I try to help men like grasp and understand, and then figure out how do you hold tight to that to keep it out front to help qualify your decision making. The decision making of, okay, hey, what happens next is a conversation between the doctor, but I think the doctors will say ultimately you have to make the decision. There's very rare scenarios, if any, I guess, where they're going to force you into a situation. So you have to decide, okay, doc, let's, after reviewing or after discussing all of the alternatives, I think this is going to be the best one for me. I'll tell you this, the thing that sometimes is missing, and this is what, this is why I have these conversations with other men as well. You've spoken to the doctor, you've thought through it. Okay, did you really understand what the doctor said? Have you asked enough questions, and have you broken this down for the pros and cons? And are you making the right decision for you? Right. And I think sometimes they lean so hard on the doctor, and I don't envy you all, because they basically, in their minds and in my mind, sometimes you're saying, well, I'm putting my life in the doctor's hands. And which is appropriate because they have the knowledge, the information, but you also need to be comfortable by asking enough questions and then potentially having some dialogue. And so that's the part that I get into, which is the dialogue with different patients. And they want to, they want to ask those deep, hard questions, I think, sometimes, to understand what happens after all of this is done.
Absolutely. So let's get to some final thoughts. And if there's any resources that you can direct either healthcare providers or general, folks like myself to, please mention that in your final thoughts. We'll do caveman style. We'll go ladies first. Dr. Bill House. Final thought.
Final thought is that coming prepared helps a lot. Coming with some idea, and you don't have to know everything. We certainly don't expect you to, but that helps a lot. And knowing and your why. I love that. Like coming in with your why, because when it gets uncomfortable, you'll just remember your why. I think this is a good resource. Full disclosure, I was involved in this, but Janssen Oncology has a website called talkthattalktime.com, which is for Black men in particular, and just how to start that conversation with their doctors, how to start their conversations with other Black men. I think it's super important that that's really the starting point here to get patients informed. .com, not .org.
All right. And Dr. Langford.
Yeah, I was just writing that down. That's really cool. I think, I'm just going to go and say that, ultimately, I think final thoughts, love yourself, want the best for yourself as a patient. Go in there and pursue your better interest and try to get the treatment that you deserve, that you want, that you need. And, go in there with that desire. And for the doctors, have empathy, care about your patient, care about the impediments and the difficulties that they're going through to get the things that they need, and help them get them.
Absolutely. Well, I want to say thank you all for joining us this evening. Thank you all for watching us. I did put a website, it's for MoMENtum.com. That you can also find some other resources from our partners at Myovant for helping us with this particular production. I do want to add one more thing for healthcare providers, particularly if you're a family medicine or general practitioner. Have a good list of referrals to urologists. Don't try to take on all that. When somebody has an elevated PSA, have a good list and refer them to a good urologist and let the urologist do what they do. Because you've got a lot on your plate as a general practitioner. You're looking at a lot of things. You're looking at diabetes and kids and family. It is a lot. You heard this conversation tonight. All of the different things that people need to know. Don't try to put that on your plate. Have some people that you can refer them to very, very quickly, that they can get the information from somebody that specializes in that. Men, brothers, get checked, get screened. I have a family history, much like Terrell. My father had prostate cancer. I started getting screened at 35 because I was very, very concerned about it, and still continue to get screened and ask about it. And doctors tell me about other stuff I got going on. I'm like, no, how's my PSA? I just want to know how my PSA. I didn't come here for all that. I didn't come here for my cholesterol, doc. I came here to get a PSA check. That's what I came here for. But in all seriousness, men, we have to get checked, and we have to have these conversations. So I want to say thank you. Continue to have these conversations in your families as you gather this holiday season. Have some real health conversations. It can literally save a life. So again, thank you all for joining us, and we will see you next time here on blackdoctor.org.